Welcome back to the Deep Dive. I know you guys are back for more cardiology, and I know you're especially interested in the tricky world of heart failure. So luckily, you're in the right place, because today we are diving straight into the 2021 ESC guidelines for the diagnosis and treatment of heart failure. Fresh from the European Heart Journal, Volume 42.
Happy to be here.
And I've got a real heart failure guru with me to help us sift through it all. So let's get started. First off, when you see a patient in the ER, what exactly IS heart failure? The guidelines seem really set on defining it as a syndrome, not a single disease. What does that mean for you practically?
You're absolutely right. The ESC guidelines are laser-focused in calling heart failure a syndrome, and that means you can't rely on one specific presentation. You've got your classic breathlessness, fatigue, maybe some ankle swelling. But all of those are just signs pointing to the heart not doing its job properly. You have to think about it as a complex web of factors, not just one simple problem with a simple solution.
This is more like a puzzle than a straightforward diagnosis.
Exactly. And that's why it can be so tough to manage, especially in the ER. You'll see patients with chronic heart failure coming in with flare-ups, but then you'll also have those presenting with acute heart failure for the very first time. Each situation needs a different game plan.
Right. Now, we hear a lot about decompensated heart failure. Is that the same as acute heart failure, or is there a subtle difference there?
Great question. There is a difference. Decompensated heart failure usually refers to a worsening of existing heart failure. So think of a patient who's generally stable, but then something throws them off, like an infection or a medication change, and their symptoms suddenly get worse. Acute heart failure, on the other hand, is the initial onset of the syndrome, like you said.
That makes sense.
Mm-hmm.
So a patient with chronic heart failure can decompensate, but we wouldn't call a first-time presentation decompensate.
Exactly. Now, whether it's chronic or acute, one of the first things you want to do is figure out where they fall on the heart failure spectrum. The ESC guidelines break it down into three main categories based on their left ventricular ejection fraction, the LVEF. You've got those handy in the guidelines, right?
Always. Let's see, we've got HFrEF, HFmrEF, and HFpEF. I'm guessing I'll be seeing those acronyms in my sleep soon.
They'll become your new best friends, trust me. So HFrEF, that's heart failure. With reduced ejection fraction, their LVEF is 40% or less, meaning their heart's not pumping out enough blood. Then you have HFmrEF, heart failure with mildly reduced ejection fraction. This one's a bit of a middle ground, with an LVEF between 41 and 49%. And finally, HFpEF, heart failure with preserved ejection fraction in this case. The LVEF is 50% or greater, but the heart's still not working as it should, even though it seems to be pumping out a normal amount of blood.
It sounds like we shouldn't get too hung up on just the LVEF number then.
Exactly. Well, these categories are helpful. There's always some debate about the specific LVEF cutoffs, especially when it comes to HFmrEF, the EACVI. The European Association of Cardiovascular Imaging actually has different thresholds for men and women when defining systolic dysfunction.
Different thresholds for men and women.
It turns out a normal LVEF can vary slightly between sexes. For men, systolic dysfunction is considered an LVEF under 52%, while for women it's 54%. It's a subtle difference, but it highlights how important it is to look at the whole picture with each patient.
That's a good point. So we have this whole spectrum of heart failure. But what kicks it off in the first place? I'm looking at Table 5 in the guidelines, and it seems like there are a ton of potential causes. Everything from coronary artery disease to heavy metal poisoning.
It's a surprisingly wide range. That's why getting a good patient history is so crucial. You have to be a bit of a detective, piecing together the puzzle of what's going on with each individual. Some causes are definitely more common, though, particularly depending on where you're practicing. In developed countries, for example, coronary artery disease and hypertension are often the main culprits.
So location plays a role, too. Are there any other surprising causes we should keep in mind?
Yes, definitely. Besides heavy metal poisoning,
right,
which can directly damage the heart, you've got nutritional deficiencies like thiamine or vitamin B1. That can lead to something called beriberi heart disease. Autoimmune diseases like lupus and rheumatoid arthritis can also trigger inflammation. That affects the heart.
Wow. So it's not just the usual suspects we need to consider. A lot of different possibilities.
Exactly. Now, once you've figured out the likely cause, the next step is figuring out the treatment. The ESC guidelines really emphasize a multidisciplinary approach to managing heart failure.
What do you think about that? I'm all about teamwork. Heart failure is such a complex syndrome. It makes sense to bring in expertise from different areas. You can't just rely on medication alone.
Right. A good heart failure management program should involve cardiologists, nurses, pharmacists, dietitians, you name it, and of course, the patient themselves play a key role.
What about patient education and self-care? Are there any specific tips from the guidelines that we can share with folks to help them manage their heart health?
Absolutely. Table 12 in the guidelines gets into that, one of the simplest, but most effective. Things patients can do is keep a close eye on their weight. The guidelines recommend adjusting their diuretic dose based on daily weight changes. A sudden weight gain can be an early sign of fluid retention and a potential heart failure flare-up.
That's a great practical tip. What about medications? I know everyone's always curious about the latest recommendations for HFrEF. Can you walk us through the key drug classes?
Of course. We have a lot to cover here, but let's hit the high points. First up are SGLT2 inhibitors. They were initially developed for diabetes, but they've shown incredible benefits for HFrEF patients, regardless of whether they have diabetes or not.
SGLT2 inhibitors, they've been making a lot of headlines lately. How do they work?
They have a few different mechanisms of action, which is why they're so effective. They reduce blood sugar, obviously, but they also lower blood pressure, lessen inflammation, and even have positive effects on the heart structure and function.
Sounds like a real all-rounder. What else do we have?
ARNI, or angiotensin receptor neprilysin inhibitors, are another important class. They're relatively new, but have quickly become a cornerstone of HFrEF treatment. They're actually a combination therapy, blocking the negative effects of angiotensin while boosting beneficial peptides that support heart function.
Okay. ARNI sounds promising. Are any of the older medications still relevant?
Definitely. Beta blockers are still crucial. They help slow the heart rate, lower blood pressure, and protect the heart from further damage. We also have MRAs, or mineralocorticoid receptor antagonists, which help to balance electrolytes and reduce fluid buildup.
That's a pretty impressive arsenal of medications, but of course with any medication comes the possibility of side effects. Are there any we should be especially careful about when prescribing these drugs?
You're absolutely right. Monitoring is key. With all of these medications, hyperkalemia is one of the most common issues we see, especially with MRAs. So checking potassium levels with regular blood tests is essential. And of course, keeping an eye on kidney function is crucial, as many of these medications can affect the kidneys.
Makes sense. We'll be sure to emphasize those monitoring points. Now, before we wrap up this section, I wanted to touch on iron deficiency and anemia. The guidelines mention that these are linked to increased mortality and heart failure, which is pretty concerning.
It is a concern, and unfortunately, it's often overlooked. The good news is we can do something about it. First, we need to diagnose it. That involves checking serum ferritin and transferrin saturation. If we confirm iron deficiency, then we can consider iron supplementation, especially for those with HFrEF.
Well, iron supplementation isn't just for anemia anymore. It could potentially be life-saving for heart failure patients.
Exactly. It's all about optimizing the blood's ability to carry oxygen and helping the heart function at its best. And that actually segues perfectly into our next topic, device therapy. Device therapy can be a real game changer for some patients with heart failure. One of the most important devices is the implantable cardioverter defibrillator, or ICD for short. These devices are constantly monitoring the heart's rhythm, ready to deliver a shock if a dangerous arrhythmia happens. Think of them as a little backup system, just in case things go wrong.
Right. ICDs, they can literally shock the heart back into rhythm, right? Yeah. This is pretty intense.
They are pretty amazing pieces of technology. But like you said, it's a powerful intervention, so it's not for everyone. The guidelines are very clear about who should get an ICD. It really comes down to the individual's risk of sudden cardiac death based on things like the severity of their left ventricular dysfunction.
So it's not a one-size-fits-all approach.
Yeah.
There's a real decision-making process involved.
Absolutely. We always weigh the potential benefits against the risks. Like any procedure, there are some risks with ICDs. One of the things we watch out for is inappropriate shocks, where the device fires off when it shouldn't. Naturally, that can be pretty upsetting for the patient.
I can imagine. So the way the device is programmed plays a big role in minimizing those risks.
You've hit the nail on the head. The programming needs to be tailored to each individual, taking into account their unique heart rhythm patterns and their overall health.
Okay, that makes sense. Now, the guidelines also mention cardiac resynchronization therapy, or CRT. That's another type of device therapy, right?
Right, CRT. This therapy is a bit more specialized. We use it for patients who have problems with their heart's electrical conduction system, which causes the ventricles to beat out of sync. CRT helps to get those contractions coordinated again so the heart can pump more effectively.
So if I'm understanding correctly, ICDs are all about preventing sudden death from arrhythmias, while CRT focuses on improving the overall pumping function.
That's of the heart.
Exactly. And like with ICDs, choosing the right patients for CRT is essential, the guidelines recommend it, for patients with specific EKG findings, like a wide QRS complex, which indicates that there's a delay in the electrical signals traveling through the heart.
It's pretty incredible how advanced device therapy has become. It gives us so many more options to manage heart failure.
I completely agree. And for some patients, these devices can act as a bridge to a more permanent solution, like a heart transplant. That brings us to the topic of advanced heart failure, those patients who are in the later stages of the disease. That can be a really difficult conversation to have. I noticed the guidelines use something called intricacies profiles to help guide treatment decisions for those patients. Can you tell me more about those?
Intricacies profiles are a way of categorizing patients based on how severe their symptoms are and how urgently they need some kind of intervention. They range from profile 1, which is the most critical, to profile 7, which is the least urgent. These profiles help us determine whether a patient might be a candidate for heart transplant, a mechanical circulatory support device, or palliative care.
So it's a tool to help figure out who needs the most intensive interventions first. But I imagine there are a lot of ethical factors to consider too.
You're right. Decisions about advanced heart failure are incredibly complex. We have to think about the patient's wishes, their quality of life, and the availability of resources. Palliative care often becomes a crucial part of the conversation because it's all about ensuring the patient's comfort and dignity, no matter what treatment path they choose.
That makes a lot of sense. It's not just about keeping someone alive. It's about making sure they have a good quality of life too.
Exactly. And sometimes the kindest and most compassionate approach is to shift the focus to comfort measures instead of continuing with aggressive treatments.
That's a really important point. Now, let's switch gears a bit and talk about acute heart failure. What are the key things that make it different from chronic heart failure, especially when you're working in the ER?
The main difference is that with acute heart failure, the symptoms come on much more suddenly, which means we need to act fast. Patients often present with things like severe shortness of breath, a rapid heartbeat, and signs of fluid buildup. They need to be assessed and stabilized quickly, often with IV medications and continuous monitoring.
One of the things that always comes to mind with acute heart failure is cardiogenic shock. It's a scary scenario, but I think it's important to talk about. What are the warning signs we should be looking out for, and how do we manage it?
You're right. Cardiogenic shock is a serious medical emergency. It's basically when the heart can't pump enough blood to meet the body's needs. It's often caused by a major cardiac event, like a massive heart attack. You'll see very low blood pressure, a weak pulse, changes in mental status, and signs that the organs aren't getting enough blood flow.
It sounds like a race against time to get their circulation back on track.
It absolutely is. We treat aggressively with medications to support blood pressure
and heart function.
Sometimes we need to use mechanical circulatory support devices. And, of course, we have to address the underlying cause, which may involve procedures like coronary angioplasty.
Cardiogenic shock. Definitely something we want to avoid. Speaking of complications, what about the comorbidities that often go hand in hand with heart failure? Atrial fibrillation, or AF, seems to be a pretty common one.
AF is definitely a frequent player in the heart failure story. The guidelines actually call it a frequent deleterious comorbidity, and they're right. It's a bad combination.
It sounds like a vicious cycle. AF makes heart failure worse, and heart failure makes AF worse.
Exactly. They each strain the heart, increasing the risk of stroke, hospitalization, and even death.
So how do we manage these two conditions together?
It's a multi-pronged approach. First, we need to control the heart rate during AFib, often using medications like beta blockers or calcium channel blockers. Then we have to think about preventing stroke with anticoagulants because AF significantly increases the risk of blood clots forming in the heart.
And we can't forget about managing the underlying heart failure using all those strategies we talked about earlier.
You're absolutely right. It's all about having a comprehensive plan that addresses both the AF and the heart failure.
Now, another common comorbidity we see with heart failure is coronary artery disease, or CAD. What special considerations are there when a patient has both?
CAD, which involves blockages in the arteries that supply blood to the heart, is actually a very common cause of heart failure. When a patient has both conditions, we have to figure out how severe their CAD is and whether revascularization procedures like angioplasty or bypass surgery might be appropriate.
So sometimes we need to address those blockages directly to improve the heart's function.
Sometimes, yes.
Yeah.
A complex decision, patients with heart failure are often at higher risk for complications from these procedures.
That makes sense. The risks and benefits need to be carefully considered for each patient. Now, I'm curious about some of the less common, but still fascinating, conditions that can contribute to heart failure. Amyloidosis comes to mind. It's mentioned in the guidelines, but I'm not that familiar with it. Can you give us a quick rundown?
Amyloidosis is a rare disease where abnormal proteins accumulate in the body's organs and tissues, including the heart. This buildup can stiffen the heart muscle, making it harder for it to pump efficiently.
It's like the heart's plumbing gets clogged with this protein gunk.
That's a great way to put it. It can be tough to treat, but there have been some encouraging new developments. In recent years, medications like tafamidis have shown real promise in slowing the progression of amyloidosis and improving outcomes for patients.
Okay. Amyloidosis, I'll definitely be reading up on that. It's amazing how many different things can lead to heart failure.
It really is. It highlights how complex the heart is and how susceptible it is to damage. And while we're on the topic of things that can damage the heart, we can't forget about sleep-disordered breathing.
Sleep apnea. I wouldn't have thought of that as a major contributor to heart failure.
It may seem surprising,
Okay.
but there's a definite link between sleep apnea and heart failure. When you constantly stop breathing during sleep, it puts a lot of stress on the heart. It can raise blood pressure and increase the risk of arrhythmia.
Just snoring isn't always just an annoyance. It could be a sign of something more serious going on.
Right. The good news is that we have effective treatments for sleep apnea, like continuous positive airway pressure, or CPAP, which can actually improve heart function and reduce the risk of these complications.
Well, I'm glad to hear there are effective treatments. We've covered so much ground today, and I have to say, I'm feeling a little overwhelmed, but in a good way. It's incredible how much we've learned just by digging into these guidelines.
I agree. It's a lot to take in, but it's also important for providing the best possible care for our patients with heart failure.
Well said. I think it's shift gears and talk about some of the most important takeaways from this deep dive. What are the things you really want folks to remember about the ESC, heart failure guideline?
Absolutely, if you're taking away just a few key things from today's conversation, here's what I want you to remember. First, heart failure is a syndrome with many different faces. It's not just one disease we have to approach each patient as an individual, taking into account their specific presentation, their medical history, and their goals of care.
That's a good point. It's easy to get caught up in the technical details and forget that we're treating a person, not just a set of symptoms.
Exactly. And speaking of those details, early diagnosis is absolutely key. We need to be on the lookout for those classic signs of heart failure, things like breathlessness, fatigue, and edema. And we need to use our diagnostic tool effectively. Don't forget about those natriuretic peptides. They can help us rule in or rule out heart failure quickly and efficiently.
They're like that. Our secret weapon of the ER. So, early diagnosis is important, but then we have to figure out the right treatment strategy. And it sounds like that strategy should involve more than just
medications.
You've hit the nail on the head. We've talked a lot about medications today, and they are a crucial part of managing heart failure. But we can't stop there. It's really about taking a multidisciplinary approach, bringing in experts from different areas to provide comprehensive care. We need to address those comorbidities that often complicate things like AFib and CAD, and we need to help patients understand their condition and take an active role in their own health. You mentioned patient education. What are some practical things we can encourage our patients to do to help manage their heart health? Besides keeping an eye on their weight, of course. That seems like a really important one from the guidelines.
Yes. Monitoring weight is huge. It's such a simple but powerful tool for patients to use at home. Beyond that, we want to encourage heart-healthy lifestyle choices. We're talking about regular exercise, a balanced diet that's low in sodium, and stress management techniques. And let's not forget about sleep. We talked about how sleep apnea can worsen heart failure. So making sure our patients are getting good quality sleep is crucial. Sometimes that means referring them for a sleep evaluation or helping them find the right CPAP therapy.
It's amazing how much of a difference those lifestyle changes can make. They might seem small, but they can have a big impact on someone's overall health and well-being.
Absolutely. And it's important to remember that heart failure management is constantly evolving. New research is coming out all the time. New drugs are being developed and new devices are being tested. It's an exciting time to be in cardiology, despite all the challenges.
Seems like we're always learning something new. And these guidelines
are a great way to stay up to date on the latest evidence and recommendations. But I think it's important to emphasize that they're just
a starting point.
right.
Okay.
Guidelines are helpful, but they can't replace clinical judgment. We always have to consider the individual patient in front of us and tailor our approach to their unique needs. That's why it's so important to stay curious, keep learning, and never be afraid to question the status quo.
That's a great point. It's easy to get comfortable with what we know, but we have to keep pushing ourselves to learn and grow.
Exactly. And don't forget, collaboration is key. We can learn so much from each other, whether it's through case discussions, journal clubs, or just informal conversations with colleagues.
I couldn't agree more. Sharing knowledge and experiences is how we all get better. So to everyone listening out there, thanks for joining us on this deep dive into the ESC heart failure guidelines. I hope you found it helpful and maybe even sparked some new ideas or questions.
I hope so too. It's been a pleasure discussing this important topic with you.
And to wrap things up, I want to leave you with a thought. Heart failure is complex, but it's not insurmountable. With the right knowledge, the right tools, and the right mindset, we can make a real difference in the lives of our patients. Keep learning, keep asking questions, and keep striving to provide the best possible care. That's what it's all about.